You will have heard on EASD TV about the Global Council of EASD. Now, one of their first initiatives has been a Global Impact Prize to go along with the other prize lectures that we have here at the EASD Congress. And I'm delighted to welcome the very first recipient of the Global Impact Prize, and that is Dr Mohan Viswanathan, better known to everybody simply as Dr Mohan, who has been associated with diabetes in his native India his whole life. And it's a family business.
Yes.
Because your father, as I understand it, was the first diabetologist in India.
Yeah, that is true. So my father, Professor Viswanathan, was called fondly as the father of diabetology in India. And his work started in 1948 when he started the first diabetic clinic in India, post-independence. So 47 we got independence, and 48 he started the clinic. From 71 till date, I've been working in diabetes. And actually, when you said it's a family thing, I was smiling because my daughter, Dr. Anjana, is now the head of our institution. I'm the chairman and she's a managing director. So she has been with me.
But she could hardly avoid it, if I may say so.
Yes, it's very difficult. And so is my son-in-law.
So keeping it in the family. So in India, diabetes is an extraordinary problem. Yeah. You have, I think, 1 in 4, something like that, of population affected. And what's driving that enormous rise in diabetes?
It's a subject which we have been researching for many years. So South Asians, so Indians, Pakistanis, Bangladesh, Sri Lankans, Nepal, we seem to have this excess susceptibility to not only just type 2 diabetes, but also to cardiovascular disease. Part of it is probably genetic. This is driven probably by consanguinity because people keep marrying within the family for generations, and so the gene has probably multiplied. But certainly that can't explain the rapid rise, because the genes were the same 50 years ago when you had 2% diabetes in the cities, and today we have 25% of people, 1 in 4, as you said, in the major cities who have diabetes. So we did a study which covered the whole country, every state, urban, rural representation. It's called as the ICMR INDIAB study. 124,000 people, representative of India's 1.44 billion, totally representative. So from there, the numbers that we got for diabetes was 101 million people. That's almost twice the population of UK, and just with diabetes. And then if that was not enough, we had 136 million people with pre-diabetes. So if you add both that together, it's 237 million people who have either diabetes or pre-diabetes. Now, when you say 1 in 4, it gives the impression that 3 out of 4 won't get diabetes. Well, this 1 in 4 is people above 20 years of age. So if you take 50 years and above as the cut point, by that time, diabetes is present in half the population, 50%. It's just like the Pima Indian story or the Naru Indian. They're small populations where they have 50% diabetes. Today in the cities, big cities of India, 50% of people have diabetes at age 50, and another 25% have pre-diabetes. So it's actually 1 in 4 who don't have either diabetes or pre-diabetes at a older age group.
And is that driven by urbanisation as well, and diet? Because the South Asian diet tends to be carbohydrate rich, doesn't it?
Yes. We are finding many clues to that, and carbohydrate is certainly one of them. In fact, we have both cross-sectional studies as well as longitudinal studies over 10-15 years to show that rice intake as well as wheat intake, so the carbs, you're absolutely right, is one of the drivers of the epidemic. But then that's not the only thing. Physical inactivity is another driver of the epidemic. More recently, new agents which we never thought of as producing diabetes have been discovered. For example, pollution. Air pollution in the major cities like New Delhi, Chennai, and so on, the particle size, the PM2.5 particle size, has been directly linked to type 2 diabetes. So we are discovering newer and also pesticides and other endocrine disruptors. So this is present even in rural areas. So we thought earlier it was only an urban phenomenon. Today we are saying that in the villages it's increasing. Of course, obesity is increasing, the usual thing, all the rice intake and all that we can blame. But there are newer risk factors which are also very
and
much.
And an interesting one that I had yesterday from one of the members of the Global Council who was in Kuwait is that, they regularly have 50-degree temperatures.
Yes.
And because of climate change, the amount of, these very, very hot days,
Yes.
the number of them are increasing. And of course, when it's that hot, you don't exercise.
Yes. So it's probably linked to that. When it's so hot, you don't exercise, and then also when you have so much of pollution, people don't go outside to exercise because they think they'll get sick if they walk.
Which is quite true.
To have a joke in India, when I tell people that it's good for your health, they say, well, if a truck doesn't kill me, the smoke of the truck will kill me, or a dog will bite me and I'll get rabies or something. So actually my life may be cut short if I do exercise. And so the thing to do is to actually find places where they can safely walk. There's no point in just telling people go out and walk if there is danger in walking. So the first thing we have to do is, of course, apart from changing, we have a new paper coming out in Nature Medicine where we have shown that if you just replace 10% of the carbs with protein, preferably plant protein, but any protein is fine, but not with fat. If you replace the carbs with fat, nothing happens. But if you replace it with protein, that works. And if diet and physical activity, if you improve that, 50% of new onset diabetes can be prevented.
Which is extraordinary. So this is called the Impact Prize.
Yes.
And I know that you outline some of the impact. So what really are you most proud of in terms of impact?
First of all, building diabetes as a specialty was something very new because physicians said, okay, I treat everything else and then I also treat diabetes. We converted that into a specialty because we said you need to spend time with patients. We need to have educators. So training hundreds, now thousands of doctors all over India, and now having diabetologists established all over India is one of the accomplishments. The other one is diabetes educators. Until 1995, we didn't have a single diabetes educator. Through the National Diabetes Educator Program, which we started, today we have 29,000 diabetes educators in the country.
29,000, wow.
Yeah, it's not enough probably, but it's still better than zero. And then, of course, research into things which really have a translational value. It's not esoteric research, which you just do, publish a paper in Nature or Lancet, and then nothing happens after that. It's not that. So every research project that we have done has some community translation, whether it's prevention of diabetes, newer methods of diagnosing diabetes, or technology, use of CGM, use of pumps, the genetic, studying the genomics. One of the big things that we are very happy about is something which Dr. Andrew Hattersley spoke about in his lecture yesterday. In fact, he has been one of our mentors, and we closely follow the Exeter model for monogenic diabetes screening. So we have a child who's, say, 3 months old, diagnosed to have type 1 diabetes and told to take insulin lifelong. And then the child comes and we do a simple genetic test which tells us, hey, you've got a KATP channel deficiency,
all
mutation.
You need is sulfonylurea
Take them
tablets.
off and give them sulfonylurea. It's completely life-changing. The child doesn't need insulin at all. So this is one of the things that you're really proud of.
Fantastic. And yes, the genomic approach is proving extraordinary, isn't it? And the other thing, I guess, is about technology, because CGM, for type 1, I mean, now I think in the UK, 97% of people with type 1 have CGM, and there's a move as to whether, population in type 2.
Yes.
But in India, you have a huge, the 101 million, that's an enormous resource implication. Yeah. So where are you moving in India with technology? So, because, of course, India is a hugely technologically literate country.
So that's one of the differences that we have with the UK, for example. With your NHS, you're able to give equitable care to the entire population. Obviously, your population is much smaller. When you have 101 million people, it's not easy for even a government to give everybody CGM and all those on insulin, a pump, or an automated insulin delivery device. The costs are huge. And while in the government hospitals, everything is given free, that means those are below the poverty line, it'll be basic care. So they would get them metformin, basic insulin, but the pumps and the CGM are still out of reach. So we are looking for, in the case of medicines, for example, GLPs or the SGLT2s, generics come in. So once the generics come in, the price drops 70%, sometimes even 90%. So a large number of people can afford it. And now the WHO has included it in that essential drug list. So it's only a matter of time. We want similar things to happen to CGM because the same thing happened with the blood glucose meters some time ago. I remember 30 years ago when we started collaborating with some of the big companies to reduce the cost. The cost of a simple glucometer was 1 month's salary of a person. So nobody was buying it and nobody was using it. We persuaded them to reduce the cost by 90%. And suddenly there was a rise in the self-monitoring of blood glucose. Same thing we are hoping will happen with CGM. That the CGM gets cheaper and more affordable, then everybody should be on it. I can't see why any person with diabetes should not use a CGM. So it will take time, and then maybe some indigenization has to occur, or reimbursement. If the insurance is able to pay for it, if they think it's worthwhile, then it will become affordable. Until then, the top bracket, the first 10%, 15% of the richest people will probably take it. Others, if some company pays for it, if your employer is giving it to you, the rest are deprived about it.
Now, your career in diabetes already extends, I think I'm right in saying, to 50 years.
50 years, yes.
I suspect that you will be doing things with diabetes until the day that you depart this earth.
Hopefully.
I think there's no stopping you. But you've mentioned the CGM and GLP-1s as being, future things that you want to see rolled out more widely. But is there anything in particular that you really want to see happen in diabetes in India?
A cure for type 1. Because with the automated insulin delivery systems, in my life, I'm seeing for the first time normal glucose levels in a type 1 patient with no hypoglycemia, something which is unthinkable, unbelievable. So that's happening. But they say we still have to buy the pump. We still have to take the insulin. We still have to pay for the consumables, and we have to do a lot of things. We're not cured. So now with the stem cells coming in and better methods of replacing insulin becoming available, it's no longer science fiction. I think the day is not far off before we would have a total cure for diabetes. And that's what my patients keep asking. You keep getting all these awards. 50 years you've been doing everything, and now we're still taking
Mohan.
insulin.
What are you doing? You've been just sitting around.
They don't care, because they say I'm still taking my insulin, and all your awards don't help me. So you find the cure. And once you find the cure, that's the real contribution to diabetes. So I think at least for type 1. Type 2 is going to be more difficult because it's a lifestyle-related thing. But for type 1, I think we are closing in slowly. And I can see, I don't give a date because in 1970s, when first islet cell transplant and pancreas transplant came, we said within this decade it will happen. Like JFK, John F. Kennedy saying, before the decade we'll be on the moon. So something like that, we started saying, before 1980, you'll get a cure. And then it was 90s, and then it was 2000, and 2010, and now 2020, and 2025, and nothing has happened. So people say, you've been saying this for the last 40 years, nothing has happened. But I think for the first time now, we are moving in that direction.
I'm getting that whole sense of that at this meeting. Dr. Mohan, it's been such a pleasure talking to you. Terrific lecture. Do go and have a look at it. And thank you for all you have done. And I know you will have diabetes, that you'll be doing it still for many years to come.
Thank you very much. Thank you for having me.
There'll be more from EASD TV very soon.